So what I plan to do is take my full allotment of time and spend the next 3 hours lecturing you. And then I'll try to keep my comments. I have a tendency to go long. So I'll try to keep my comments to about 55 minutes to an hour. And I have an hour and a half. So, and then many of you have experiences that are important. Many of you have opinions. Some of them may be wrong. I'll correct them. We'll have an exchange for the last 30 minutes. But you do have permission to interrupt me at any time. I am a Texan, though. That's one of my biases. I may get violent. But it's okay. So please interrupt me. My main objective is for you to learn something. I've prepared some things that may teach you something, but I'm not sure. To let you know, thank you, Michael, for the kind introduction. Where I'm coming from clinically, I'm an internal medicine physician. I've been doing hospice and palliative care work mainly as a clinical role for about 17 years. I ran a hospice and palliative program in Birmingham, Alabama. That was at the County Indigent Hospital. I was also the chief of staff, and I did a lot of medicine there too. But one of my roles was running a dual diagnosis clinic, so people that had known addiction and terminal illness. I also helped run a clinic at the HIV Center in Birmingham, the 1917 clinic, and I've treated probably over 6,000 patients that were dying. Okay, so that's another one of my biases, is I'm not coming just from a theoretical standpoint thinking about pain. I'm thinking about the many faces of the patients I've cared for over the years. At The Ohio State, I mainly get paid to run my mouth, which, if you ask my daughters, that's what Daddy does. What's Daddy do? Daddy runs his mouth. That's nice. I do run the pain and symptom management clinic at the James Cancer Center at The Ohio State University. So I'm still involved. Bureaucracy and regulation makes me have this. Disclosures and conflicts of interest. I have none, but I welcome them. As an aside, the dean at Ohio State asked me to give a talk on conflict of interest with leaders. And I started by saying we want to enhance conflicts of interest. We want to increase them. Because that means you're a successful academic. If you actually are being called upon to be a consultant or taking an idea to market, these are conflicts of interest. That means you're successful. Wonderful. So if anyone has money and would like me to have a conflict of interest, we can talk. I'll just disclose it. The other disclaimer I have to say is if anyone has had the unfortunate privilege of hearing me speak before, I usually start by saying that I don't use PowerPoint. I break out in hives and I have an allergy to it. So if I go into anaphylactic shock, you know what's happening. Please, it's like my bracelet. I'm using PowerPoint because I found some pretty pictures that I think illustrate my point. And I knew that it was this room, and it kind of lends itself to such. So the goals of our session, I'm going to talk about the history a little bit of opioids and pain management, just to give some voices through history. Then we're going to talk about the types of pain and the expansion of opioid, why we're in an opioid crisis currently in the U.S., if you don't know. Why we are where we are. And then we'll look at, I'll have a specific focus on drug diversion and policy and some of the challenges ahead, and then we'll open to discussion. So first, what is pain? It's not rhetorical. Oh, it's on the board, I guess. Okay. So I had Chevis Langham McCord Smythe, one of my professors at the University of Texas Med School. When I was a med student, I had presented someone with excruciating pain, and he said, "Ryan, what is pain?" And I said, "Well, it's nociceptive, blah, blah, blah." I went into a little description, and I said what scale of 0 to 10 the pain was. I described it, and I described whether it was somatic pain or neuropathic pain or all these things. And he said, Now Chavez was 82 when I was rounding with him. He was the first dean of the Medical College in South Carolina, first dean at University of Texas Medical School in Houston. He had helped found Aga Khan in Pakistan as well. Trained at Harvard, brilliant guy, decided in his retirement to do rounds at the county hospital 6 or 7 months a year. Amazing man. But he said, Ryan, if I didn't have pain when I wake up in the morning, I wouldn't know I was alive. That reminds me. And evidence of life. I think there is something to that pain does in some way define us as a people. Paige just gave a wonderful talk on, an interactive talk on uterine transplants. What's one of the, after the fall, what's the curse? Pain in childbirth. And pain and suffering as you sweat, the sweat of the brow as you toil of the land. We're still on this side of the curse. And the life, we don't know life. We don't know the life of Eden. We don't know the life of paradise. We don't know life without pain and sweat and suffering. So, the pain is also, there's been much said, especially in Western Christianity. My other bias is I'm an Orthodox Christian, Eastern Orthodox, so just so you know. Those are my biases. Especially in Western Christianity and Roman Catholic tradition, there's been a great deal placed on redemptive suffering, that in certain types of suffering, or in most types of suffering, that you may be entering into the suffering of Christ and in some sort of unity with Christ in that suffering, in the midst of it. Our society, I think it's safe to say, is losing that concept of suffering, even within the so-called Christian circles. Many don't see suffering in such a way. Is it part of a struggle of life, that this is just a reality, that even if you don't accept that it's redemptive in nature, is it part of that kind of toiling the land, part of that the struggle and toil, part of the reality of life that we must wrestle against? I often tell patients when they complain about certain challenges, pain, and that keep struggling. They look at me. They're not told to struggle, especially by a palliative doc that's supposed to speak in nice, warm, soft tones and talk about their journey and how we'll make everything comfortable. No, I say struggle. When you have someone with depression, what do you tell them? Struggle. When you don't feel like doing something, that's what you should do. And that's your struggle, is to fight against, wrestle with the temptations that would draw you down. And that's, the church fathers say that's the Christian walk as well, is to, when faced with temptation, to wrestle against the evil that plagues you, even when you lose, time and time again. Some would say pain is an inescapable reality. I think that seems fair. Although we do have some pains that we can escape from and treat. Even this talk is not going to be about physician-assisted suicide, but of course Gil Meilander, who's come to this conference multiple times, I do believe, famously said that our longing to eliminate suffering some will take the step to eliminate the sufferer. So some will escape from pain by drastic measures such as sedation or even hastening death. Is pain merely a symptom to be treated, or is it a disease to be cured? Okay, so first, to back up from pain specifically, we can think about suffering as well. When I was a McLean Fellow at the University of Chicago, McLean Center for Ethics, and Mark Siegler, wonderful man, started by saying that the goal of his first slide or second slide in his first presentation to the McLean Fellows was that the goal of medicine is to relieve suffering. And I raised my hand. said, no, it's not. It's not to relieve suffering. One, he didn't say goal, he said the obligation of medicine. And I said, you can't have an obligation that can't be met. You know, I can't relieve suffering unless it's by eliminating the sufferer. And suffering is such an all-encompassing idea. I mean, I think, I said to him, I'm paraphrasing, that we must accept the finitude of medicine. Medicine can't cure suffering. Or as Paul Ramsey said, you know, we don't want to eliminate the human condition. And suffering is part of the human condition. So that is a very new dogma that medical students are exposed to regularly now, that the obligation or the duty of medicine is to relieve suffering. That's new. It's not, years past it was to treat disease, to care for those with disease, to care for the suffering, but to relieve suffering, relief may be more challenging. In palliative medicine practices, we often talk about controlling pain. Can you control pain? I can't control it. I can treat it, but I can't control it. I don't even know if I can manage it. But we use these words of controlling pain, managing pain, as if we are the master of suffering and pain. Why is this? Well, Hervé Jouvin, a French social philosopher, puts it nicely in this book, The Coming of the Body. He talks about the shift, the post-Renaissance. My daughters are homeschooled. They tell you that's called the endarkenment. Not the post-Renaissance humanism, which becomes the trinity of humanism is liberty, equality, and fraternity, has shifted in the 20th century and now 21st century to be more of to be the pursuit of pleasure, health, and security, more of a hedonism. With security, only enough security, is the point of security and health is to pursue pleasure. So it's not health for health's sake, it's health's sake in order to be able to pursue pleasure. And if people can't pursue pleasure, then it's probably not a life worth living, to use that nice German term. And they want security, but they don't want security infringing upon them unless it's to ensure that they can pursue the pleasure they want. This is a really compelling argument, and this is from a Frenchman who, I don't know what his faith may be. I don't. It's just an observation of the way the West has gone. So I ask you, if the pursuit of pleasure is the top principle in the new humanism, what's the greatest evil? Suffering. So no longer the pre-enlightenment, pre-endarkenment, the pre-Renaissance greatest evil was sin, death, and the devil, right? That was the Christian understanding. The Christian way of knowing was sin, death, and the devil. That was the great evil to be avoided. Even with uterine transplants, we did a lot of time on the can questions, the empirical, but not the avoidance of sin. You mentioned it. I'm not faulting but we spend a lot of time in our society thinking about what can we do empirically, where if the same kind of conversations would have happened in another era, less technological era, maybe they couldn't have had the conversation. Maybe they could. I'm not historically arrogant. I think we're not that different from the people that lived before us. They were smart too. There's an old icon of Saints Cosmas and Damian doing a leg transplant. There's amazing surgeries that happen in the ancient world. They knew many things. You read Galenic medicine, and you go, well, this isn't that wrong. It's just really different language. But anyway, if we could transport to medieval Europe, 8th, 9th century Europe, or anywhere within Byzantium, and have the same kind of conversation, we would really be focusing on avoidance of sin, death, and the devil. Now we focus on very different things. But suffering has become the great evil. So no longer is death the enemy, No longer a sin or evil or Satan the enemy. It's suffering. That's a real problematic shift in culture. But if you listen to commentaries, especially around assisted suicide and other things, and even the small decisions in hospitals, small decisions, you'll recognize that suffering is the thing to be avoided. Now, poppies are not new. Poppies will make them sleep. So opioids, poppy-derived, are not new. They're mentioned as early as the 8th century BC for their medicinal use. And they're still, they became very powerful. I mean, poppies and the control of poppy production has been a major political tool throughout the history since ancient times. I mean, folks, why are we in Afghanistan? Why are we concerned with Afghanistan? I mean, the Taliban is a drug cartel that control one of the largest poppy production, some of the largest poppy production in the world. It doesn't make the news, but that's one of the real understories. That's how one of the ways they're funded. Poppy production is still very important because a lot of opioids are still, they're not synthetic. Some are synthetic, but many are not. But this is a very old discussion. These are not new drugs. We have long-acting formulations, but they're not new drugs. Hippocrates, Hippocratic Oath, and Galen both commented on the use of opioids. They really didn't focus on whether they should be used or shouldn't be used and which patient they should be used in. They mainly talked about how to extract it and the different types of opium one could make. And so it's like this. There are several types of opium they discuss, but Galen states opium is the strongest of drugs which numb the senses and induce deadening sleep. Its effects are produced when it is soaked in boiling water, taken up on a flock of wool, and used as a suppository. At the same time, some can be spread over the forehead and in the nostrils. If it is mixed with a drug that mitigates its power, its effects are greatly reduced. I mean, that's most of what they say are just kind of how to extract it, how to use it. And the Hippocratic physicians and the Galenic physicians were using it. Now, the Hippocratic Oath, if you remember, if you've covered it, many of the Hippocratic physicians seem to not, if they couldn't bring cure, it's not clear that they had a duty to care for the dying. They definitely couldn't refer for kidney stone removal, right? That's in the Hippocratic Oath. No kidney stone removal. We presume that was very dangerous at the time, actually going in and trying to remove a kidney stone, but that's in the oath. One of the problems of bringing back the Hippocratic Oath has some peculiar things in it. But it's not clear that many of the Hippocratic physicians thought that they had a role in relieving the symptoms of the dying. So as a palliative physician, there's a large Hippocratic corpus that has a lot of followers of Hippocrates. Gives me a little pause about bringing back the Hippocratic tradition. Now, the ancient medicine, there was a specific Jewish, specific Muslim, specific Christian tradition of medicine as well. Many of them took on Hippocratic and Galenic medicine. They were largely practicing Galenic medicine, and many of them, especially the Christians, took the oath of Hippocrates in as much as a Christian could take it. And there's actually a beautiful icon hanging in my office that is the Hippocratic physician without, and it says that we're not swearing by any pagan gods at the top, but it's in the form of a cross, and it's very, very beautiful. But Hippocrates and Galen really didn't talk much about when to use opium, just how to. St. Basil the Great, on the other hand, trained in both Hippocratic and Galenic medicine. So in his long rules, mentions the following: each of the arts is God's gift to us, remedying the deficiencies of the nature. And when we were commanded to return to the earth whence we had been taken, and were united with the pain-ridden flesh doomed to destruction because of sin, something else lost in today, And for the same reason, also subjected to disease, the medical art was given to us to relieve the sick, in some degree at least. And then he, later in the same section, he says, with mandrake root gives us scopolamine, anticholinergic for physicians. And it gives us interesting scenes from Harry Potter and a wonderful mythology that I'd love to tell you later. But I won't go down that tangent. I won't do it. Mandrake root gives us, doctors gives us sleep, and opium, they lull violent pain. So St. Basil's saying it can be used. Now, elsewhere he says it doesn't have to be used. Okay, so there's a difference. There's a permissibility of using opium to relieve pain, but there's not an obligation. Just like he does say that the healing arts are to lengthen life and give better life, and the Christian should mainly use them, unless the Christian is consumed by disease and it's merely an encumbrance to death, or they're being consumed by the treatment of their disease and it distracts from the spiritual life. For St. Basil, it's very clear in his writing that he's not pro-bios, he's pro-zoe. Two Greek terms for life. Now, he's not anti-bios. He wants life. Bios is the imminent life, this tangible, physical life. But he places a much higher priority on zoe, the ongoing, eternal, spiritual life, seeing the biological life as temporary. And so he says, yes, we should pursue medicine and the healing arts. We can even relieve suffering, but it's not obligatory. The only thing needful is Christ, and the only thing that we must do is faithfully prepare for death. And if treatment and medicine or a disease gets in the way of preparing for death, then cast it all aside. But main point here is that there's commentary on the use of opium and opioids that dates back to, even Christian commentary that dates back to the 4th century. Now, one of the modern post-Renaissance writers, Thomas Sydenham, writes glowingly, and you'll see a trend here. The next several quotes will all go back to him. Okay, he was the grandfather of modern medicine, or great-great-great-grandfather of modern medicine. So he says, among the remedies that has pleased Almighty God to give to man to relieve his sufferings, none is so universal and so efficacious as opium. Then fast forward on 250 years, almost 300 years. Anybody know who these two people are? Sir William Osler. This side? Any surgeons? No surgeons? Okay. We'll get back to him. So Sir William Osler wrote, his writings are really fascinating. One, he wrote against medical ethics. He said, we don't want medical ethics. Now, why did he say that? I'm speculating here a bit, having read some other Osler. Why might a physician, a virtuous physician, not trust medical ethics in the early 20th century? What's that? What? Oh, okay. So there were maybe some problematic things happening. I mean, so there are a lot of early 20th century. There's some ideas that he may disagree with. I think he was really, if you read him, he sounds like an Aristotelian. He says this is a doctor issue, and being a good, virtuous doctor is all it takes. He doesn't want non-doctors commenting on his practice of medicine. That's what I think his main point, when his commentary against medical ethics is really a commentary against bioethics. It's against the rise of the non-physician telling physicians what they should do. Yeah, I understand that to a point. But he also, in much of his work, he occasionally says to avoid opioids in treating a pain, especially treating the dying, but not universally. So by the time Osler is here, morphine is being developed. Not just use of opium, but morphine is being developed. Much better compound, more predictable, not as big of peaks and valleys, but nothing like what we have now with long-acting medicine that can give you a pretty good steady state all day. But morphine was more predictable than the opium of the era. And Sir William Osler termed this God's own medicine. Now, that should sound very similar, right? This is where he got it. Osler called it God's own medicine, and on rounds he would even say, he thought the patient would be scared by the term morphine, he would call it GOM. That we need some GOM for this one. And so he used it for patients with renal colic. He used it for other patients with heart failure, and for patients with angina pectoris and having a heart attack, other things. He prescribed morphine. But he had hesitance against the prescription of morphine long-term and in the dying. And I think, this is speculation, okay? I think it's because of one of his best friends. This is William Halsted. If Osler is the founder of American medicine, Halsted is one of the founders of American surgery. Their portraits are similar because these are portraits at Johns Hopkins when they were both there. Halsted was doing early experiments with a derivative of opioids called cocaine. And he was he was doing it like the kind of research methodologies most physicians did at the time. He just started injecting himself. And he wasn't just willy-nilly injecting himself. He was trying to find a nerve and directly injecting cocaine to see if it would deaden for surgery, because the types of, when they were doing surgery, they were still using very rudimentary sedatives and no nerve block agents, right? So he was working on early nerve blocks. Early 20th century, he's working on nerve blocks, but he's using himself for a lot of them. Well, not too long after that, he becomes addicted to cocaine. And lo and behold, Osler and other friends intervene and say, what we need to do is send you to the drug treatment facility in New York, where they will transition you to this much safer medicine called morphine. And Halsted is a morphine and heroin and cocaine addict most of his life. He's one of the most successful surgeons in the history of American surgery. There are stories of how his junior faculty and his residents covered for him if he was having a problem. But he was a very high-functioning drug addict. And seeing that, I think that's one of the hesitance that Osler had in saying we may not want to always use this. Now, another historical, a bit before them, I once had a colleague at UAB who was going to China and South Korea to give talks on pain management and palliative care in China and South Korea. And I said, oh, that'll be really contextually interesting given the opium wars. And he said, the opium wars? I said, we need to have a talk. This may not go well if you don't know that the West, Great Britain mainly, in an effort to gain control, this is a common narrative. There would be challenging aspects to this narrative. But one of the narratives is that Great Britain, in an effort to gain control over China, created a land of opium addicts intentionally. It was at the same time that they were spreading opium addiction, they were also spreading Christianity. So morphine, when they send morphine over, it becomes known as the Jesus opium. Partly because it's brought over by Christian missionaries, and partly because the Christian missionaries think that it's a good thing, like Halsted, that it'd be a good thing to transition them from opium dens to morphine. Okay, but this is another instance in history that opium has had This war doesn't end in 1839, 1860. It started before then. It really continues. I gave a similar talk and had a lawyer that specializes in opioids. I was giving a talk for the governor of Ohio's opioid task force, and one of the other experts that they had, he claimed this is still happening, that this is just the pharmaceutical industry and this is the American society. I don't think so. I may be wrong historically, but knowing some of the folks that run pharmaceutical groups, yeah, they have an inducement. They want profit. They want to make money. They want to have a successful business. But I see them reacting to a market and trying to make the safest medications they can, even if though theoretically or in practice they don't always work out as well as they would in theory. But know the power associated, that the societal ills, when we say that we're in an opioid crisis, this was a major opioid crisis that brought war and really devastated a whole continent for some time. Fast forward to Francis Peabody, who I think gives this nice balance. And he calls upon Osler's words as well. He says, "My own professional and personal experience has shown me that morphine is the gift of God, but depending upon how it is used, it may be either God's own medicine or the devil's own poison." And I think that's the challenge of the clinician when you can prescribe this and relieve pain, help with suffering, help with shortness of breath, but you don't know how it's going to be used. And I tell I train palliative medicine fellows, I tell my fellows that there's so many deaths in Ohio. I say, someone has died from your prescription. I think it's true. I assume that the prescriptions that I write that go out, even though I think my patient isn't diverting or isn't abusing, isn't selling, none of that, I know if you look at the numbers, the likelihood our clinic prescribes enough opioids that someone probably dies from opioids we prescribe. We know that some of our patients unintentionally overdose or intentionally overdose. We know about those, but I think our medicines get out to other places as well. So moving forward in the 20th century, trying to get to the modern era quickly with, obviously, this is a gloss of history, a few things changed. Especially in the 1920s, you could still buy marijuana and heroin at the local pharmacy. It could be prescribed or not. The apothecary may take care of you, but you could still buy a lot of drugs that we would now consider controlled substance. You could buy them at the local pharmacy. But then increasing regulations around the time of World War II made that more difficult. Also, a more regulated business practice of medicine and business practice of pharmacy was coming about. More organized medicine. And in the 1960s, the drug culture changes, where there's questions about hallucinogens, there's questions about marijuana, there's questions, cocaine hits the market, then crack makes cocaine really cheap, and heroin was on the market, now heroin's very cheap. So we have these addiction issues. Now, one of my comments, if anyone wonders why we have the big push for legalization of marijuana, it's because people that grew up in this era are now in the seat of power. So the children of the 60s are now the legislators, and they have a presupposition that it's not necessarily a bad thing to use these medications. We have, in the palliative literature, we have a big increased exploration of hallucinogens. And some of them I know some of the physicians that are doing the studies, they were at Harvard when Timothy Leary was there. It's easy to connect the dots. And they had a lot of personal experience with those things. So why are we are where we are in our modern opioid epidemic, in part because of these two good people both I have immense respect for. This is Dame Cicely Saunders and then Dr. Robert Twycross. So Dame Cicely Saunders was trained in veterinary medicine, but then trained in medicine as well, human medicine. And she was really concerned that patients that were dying or had terminal illness were being neglected by the medical community. And she saw that patients that were dying were really quite neglected. So she started the modern hospice movement, I think it's fair to say. Some people were doing it before, but she really championed it. And Robert Twycross was one of her partners at the time. He actually came to the States and helped further the movement here as well. They used, now they did not come up with the Brompton cocktail. Cicely Saunders, when she was a medical student, actually writes a paper on the Brompton cocktail, but they changed, and the Brompton cocktail has lots, like any good cocktail, depends on the bartender, what's exactly in it. But the one that they used at St. Christopher's and other places was morphine, cocaine, cannabis, gin, and syrup. And that this helped. And now that's the kind, and yeah, chloroform water. That's the care of the dying when they started. But they started systematically looking for better ways of caring for patients in pain. And they also defined, they said, hey, a lot of this doesn't work because it's not just all physical pain. It's also social pain and psychological pain and spiritual pain. So Cicely Saunders helped define these 4 domains of pain and suffering. And this was a good observation, that not all pain is physical. Now, she didn't try to, those of you who hear me run my mouth more tomorrow, I'll talk more about the control aspect of palliative care and how the danger of trying to control those psychological, social, and spiritual aspects of the person. But they didn't try to control things. They were really just trying to use medicine to help as best they can. But they moved from a simple cocktail that was kind of a shotgun approach to pain and suffering to really studying pain and the dying, and the dying process, where they became far more precise on what medications, how they're going to affect the patient, what's a proportionate dose, how long does it last. They really increased the evidence and science behind the care of very ill patients. The American hospice movement takes a different, in the UK, I have to tell my Ohio State students, that doesn't mean Kentucky. In the UK, the hospice movement is very much institutional based. In the US, the hospice movement is home based. It's trying to return, instead of institutionalizing death, trying to return them home. That's changing now, but that's a different lecture. Now, Dame Cicely Saunders and Robert Twycross are still very much engaged as there's a rise in interest in pain, hospice, and palliative care. What causes this interest? And this is my take on things. One, there's a rise of humanism in medicine. So Tris Engelhardt would say this is the 4th humanism. But there's an increasing interest in humanism in medicine that Ed Pellegrino and Paul Ramsey and actually mentioned the Ohio State's history. I'm the founding director for the Center for Bioethics and Medical Humanities, but in the 60s, Chauncey Leake was at Ohio State, and if you read the foreword to Patient as Person, Paul Ramsey's famous lectures at Yale, he dedicates it, he says much of what he learned from Chauncey Leake. Chauncey Leake went to UTMB to help start the medical humanities program and recruited people like Tris Engelhardt to work with them. So I feel connected. But rise of humanism in medicine was really of interest. The bioethics movement had started really in the 60s and moves forward and is really taking hold in the 80s and 90s. Hospice and palliative, it's hospice movement in the 80s and 90s, palliative late 90s. And I really think it's cancer and HIV that capture the public attention. So movies like Wit, which is actually a play, if you get to see the play, it's much better than the movie. But the movie's good. I think the movie Wit changed medicine. A lot of medical schools did the Wit project. Many still do. Wit is about a John Donne scholar who gets cancer, and it puts in contrast John Donne's poetry and how Donne sees life and death and struggle versus, even though he's a horrible theologian, anyway, versus the oncologist who sees a reductionistic epistemology of efficient causation. Exactly what am I going, I'm going to treat this and kill this cancer, never paying attention to the patient. It's a really powerful story, and for a couple of decades, many medical schools have had every medical student watch it and have small groups on it, and I think it's changed medicine. The focus on the money that HIV, the focus of cancer and HIV and the money that it brought in, the establishment of comprehensive cancer centers like Sloan Kettering and MD Anderson, and now there's 12, and the influx of money to cancer, the influx of money to study and treat HIV/AIDS, brings national attention to death and dying and suffering. To such an extent that pain becomes the fifth vital sign. So Joint Commission for Accreditation of Hospitals and many other regulatory groups start saying in order to meet the standard of care, not best practices, started as best practices, but then it became to meet the standard of care, you have to measure the fifth vital sign, pain. What's the pain, so on a Likert scale, 0 to 10, 10 being the worst pain you ever had, if you're a drug addict coming into my hospital and you haven't had a hit of heroin for 16 hours, what's your pain score?
10.
Probably 12.
12.
It's probably 12. But as my hospital, if I write down your 12 or your 10 and I don't have an action plan, it's a red flag. All right, this is the danger of outcome-based medicine, value-based purchasing, hogwash. It's garbage in, garbage out. If you have, so we estimate at Ohio State Medical Center that one of our addiction specialists estimates between 20 and 30% of all of our patients, of our inpatients, are drug addicts or have some sort of aberrant drug use. That's the problem. So when I started at Ohio State, the patient experience people came to me and said that my goal for patient satisfaction, and patient satisfaction being a number above 8, and that they would, the most important one, that they would suggest me to their family and friends, that my goal was 90%. And I said, no, it's not. I said, well, we didn't ask you. And I said, no, I'm not going to have it. I will consider myself a failure if I have, it's kind of like giving ethics talks. If I get 90% approval, it means I didn't say anything. I need to make at least 15% of people angry. But no, so if in my clinic, if the general hospital population is 20 to 30% patients with drug addiction or drug abuse, my clinic that I run probably has much higher. And if they're satisfied with me, if some of them who want treatment, great, I'll treat and they'll be satisfied and we'll have a good therapeutic relationship. But some of them just want their drug, thank you very much. They should hate me. They should be calling the medical board against me, which they've done. And which gives another problem. You know how hard, every complaint the medical board has to, I actually helped create a new category, I think, with the medical board because I caused a little bit of a ruckus when I got a complaint. And I said I should never have, this is frivolous, retaliatory, and it's clear this person is a drug addict. They're on cocaine and heroin. I'm not prescribing for them. This is retaliatory and frivolous. The Ohio Medical Board didn't have a category for retaliatory and frivolous, and they created one. I got a letter in the mail saying, this is retaliatory and frivolous. You don't have to report this ever again. Because you have to report it every time you get privileges for a hospital or insurance or anything like that. So I don't have to report it according to the medical board. I have the paper to prove it. So this was I'm old enough to know that when the pain was the fifth vital sign, if I would have been invited to give a talk, I would have said, we need to do this because we need to care about pain. We need to stop neglecting our patients. But it becoming an outcome measure that's true for all across the board and doesn't take that clinical wisdom into account is very problematic, and I think has really helped further the opioid epidemic that we have. Now, we've also, in this era, pharma did something fairly amazing. They came up with long-acting medications. Now, there was a long-acting medication already called methadone. Its original name was Dolphine, which it was developed by the Germans during World War II because they ran out of morphine. Again, it's very bad to run out of morphine. We actually, for a time, I don't know if we still do, at Fort Knox, we had a stash of morphine in case of wartime, if levels decreased. And Dolphine is not named after Adolf Hitler, though. It's Dol, fiend, finisher of pain. Okay? But methadone is a synthetic opioid, and it is long-acting, but it's kind of special. But now we have long-acting morphine, long-acting oxycodone, and other things. And as those drugs came about, there was a dogma that spread through medicine. That is, one, you have to have a pain score that's lower than, pick your number, lower than 6, lower than 4, depends on what your hospital or your group wants to choose. Then the way you were supposed to do pain management was you're supposed to have a long-acting medicine to keep them level, and then short-acting breakthrough medicine. Well, that was for dying patients. And what we're finding out is for chronic patients, that probably builds addiction. Especially these short-acting medications in the wrong patient population just increases tolerance so much, and it really creates a problem for a lot of patients, even post-surgical patients. You think of someone like Rush Limbaugh, who I think he publicly said he had a problem with opioids after a procedure, right? So you have people even with low addiction potential, and you put them on the kind of standard of care for great pain control, and it's a problem. Okay, then there are ethical justifications over some of the challenges of opioids. So in the 70s and 80s, Cicely Saunders and Troy Cross had to deal with people saying, no, if you use morphine in someone who's dying, they're going to die faster. So people resurrected an old Thomistic, Thomas of Aquinas, doctrine called the doctrine of double effect. Now, because you're all good students and you're a good program, you know that the modern doctrine of double effect does not resemble that of Thomas of Aquinas, because Thomas of Aquinas used self-defense as his example, which means if Mike Sleesman, sorry, I'm going to be violent, is coming at me with a knife and being a good Texan, you know I'm carrying, not real. Now, I should never admit if I'm not, but, and I pull my gun and I shoot him. Thomas Aquinas said, well, my intent was self-defense, therefore it was justifiable because even though I didn't intend the bad effect of killing, I intended self-defense is justified. But modern doctrine of double effect and modern Thomists would say that doesn't qualify because that's a causal chain. In order for me to defend myself, I have to shoot him and kill him, or at least maim him. But I was taught to shoot to kill. So, and I'm a good shot. So the modern doctrine of double effect, which is another lecture, is developed. It's resurrected. It really isn't in the medical literature much until the rise of the hospice palliative movement, the increase in opioids. And it's first saying, well, your intent is to relieve suffering. And if your intent is, and it's not necessarily so that your dose is going to cause death or hasten death, and it's also proportionate. It has to be really bad suffering, that if there's an untoward, an unexpected outcome, a bad outcome, and it does hasten death, it's justifiable, it's ethically defensible because you didn't intend it, because it wasn't necessarily so, it wasn't a causal chain, it was a causal fork, but that's another lecture, and because it was proportionate. Now, that became misused by some who would say, nudge, nudge, wink, wink, I'm going to give a giant bolus of morphine to relieve suffering. That's my intent, but we know it's hastening death. And it's still probably used in many hospices, many hospitals. We saw the famous case in New Orleans where the defense was, during Hurricane Katrina, I'm giving large doses of opioids to relieve suffering as someone dies, but they die like that. The double effect is used and misused. I don't believe that the doctrine of double effect is valid, but I do think it's interesting, but I have a theological basis for that, which is another discussion. If we have time in Q&A, you can ask me if you're interested, but know that the defense gave a license for many people in the pain and palliative and hospice and palliative movement to prescribe things knowing that they may be dangerous, but they bought that there's an ethical dogma, a doctrine that defends them, as long as their intent is to relieve suffering. Now, again, if you apply it the way a good modern Thomist would, then I think you're really not trying to kill people. You're not hastening death. You're trying to be proportionate. And now the studies are showing that if you do really good pain management, you're not hastening death. Matter of fact, people who are in distress usually die faster than those that have their symptoms managed. But I still know that there are probably many cases of nudge, nudge, wink, wink, we're going to try to relieve suffering, and death is hastened. The shift to these, the emphasis with most of these things were on HIV and cancer in dying patients. And the shift to chronic pain is a profound change. And it was not evidence-based. There was not a great evidence base that opioids over long term were going to be effective in chronic pain. So now we have an opioid epidemic. These are some advertisements or news releases from Ohio. There's a Governor Kasich has a governor's cabinet and opioid task force. I've met with some of them. They're nice folks trying to do a good job. We know that opioid prescriptions per capita in any state in the US and opioid-related deaths are staggeringly high. I mean, the opioid prescriptions, number of milligrams per person in most states is just outrageous. There is no denying that prescription opioids from physicians, legally obtained, is a large part of the problem. It's not the only problem. Heroin's very cheap. A lot of patients will switch to heroin because it's cheaper than buying their oxycodone off the street now. So in that case, a lot of times the prescription opioids are gateway drugs. Someone takes them post-surgery, likes it, and then gets cut off after 6 months because they're misusing, and then goes and replaces it with a street drug. So there are some have an ongoing abuse for prescription opioids. If insurance is paying for it, you don't have to buy them off the street. And diversion, we know, is a major issue. So one of the questions that you can now ask is double effect still as proportionate? If we have this opioid epidemic, if you think of societal impact and public health, is it still as proportionate? When we don't think about just the patient involved, but our society, our city, our state. We do restrain liberty for other public health concerns like tuberculosis, other sexually transmitted diseases like HIV? Is it time that we have more constraints for opioids? Clinically, this is my observation. This is not based on a study. This is just my observation, and physicians in the audience can see if they agree with me. And I draw this from my patients repeatedly. We actually track it in my clinic, and it bears to be true. I'm too lazy. I haven't gathered the data and published it. So by the time I see someone, they're usually on really high opioids. But what I can track over time is that their pain keeps going up. And now, this isn't my terminally ill patients. These aren't my cancer patients that are undergoing chemotherapy or something. These are my patients with chronic pain. So my chronic pain patients. They're on opioids. Their pain keeps going up. Their opioids keep going up, and their activity is going down. And I tell them the goals are exactly the opposite. The goals are to decrease the pain, increase the activity, and over time to get off opioids. But I don't see it. I mean, I'm starting to see it as I force it, and really, force it with kindness, usually. I convince, I educate, I draw this a lot, and I've had some real good successes of getting people off opioids and motivating them to do so. I've had some abysmal failures as well. But I think this is the frustration in a lot of family medicine practices and a lot of clinics across the country is you don't know what to do. They hurt more. How can I stop their opioid? Well, their opioid's not working. And as you build tolerance for an opioid, if your body is used to an opioid level that's here, as soon as you have tolerance, what's the first effect of withdrawal, the first symptom of withdrawal? Pain. It's before sweating and diarrhea, before the jitters, you're going to hurt. So as you have new tolerance and your blood level goes just a little bit lower, you're going to hurt. Well, that's the most common way opioids can cause worsening pain. And then we know there's this phenomenon of hyperalgesia, where actually opioid toxicity, opioids can cause pain through this mysterious mechanism that I won't go into. But opioids can contribute to the worsening pain. A lot of my patients that have bought into getting off, they've still hurt. And I've said, you're not going to hurt worse. But we're going to decrease your opioid every 4 weeks over the next year or so. We get them off. They don't hurt any worse, but they feel so much better. Their activity increases. They say, I didn't know I had this cloud in my thinking. I would have thought that I was fine. But once they're off, they feel a lot better. One of the challenges, because realizing these problems, people have said we should really classify pain in different ways. There's been lots of different arguments. We should have the terminal pain and treat those patients differently. We should have cancer-related pain, and there's diagnostic codes for all of these, so we have to put these things in order to collect money. There's chronic pain from whatever. There's neuropathic pain. There's fibromyalgia pain, which is special. That's a whole nother lecture. And low back pain. Specifically, opioids have not been shown very effective long-term in fibromyalgia or low back pain. We have a lot of people that are chronic pain patients because of those two things. They just don't seem to be effective. John Pepin and Shatman wrote this provocative little piece where they challenge this terminology. Read this. I mean, this is great. Terminology of chronic pain, the need to level the playing field. And they both treat pain. I mean, they're really good, solid pain docs. It said, there is frequently the caveat that those with cancer should receive opioids. So if you say cancer-related pain or terminal pain, which represents a rather strange dichotomy. This line of reasoning can be interpreted as follows. 1, we do not care if the patient with cancer suffers from side effects, fatal or otherwise, from opioids, and or develops a substance use disorder. But we do care if a patient with chronic non-cancer pain develops these problems. So the thought here is people are saying, okay, with cancer, we can use opioids, but with non-cancer, we shouldn't. Let's say chronic pain versus cancer-related pain. And so they're saying, okay, what that says to the cancer patient is, well, opioids are really dangerous. We know they're really, really dangerous. They have all kinds of problems, but because you have cancer, we don't care about those dangers. We just care about relieving your pain. But the inverse is for those with chronic pain, we say, we don't care about your pain and suffering, but we do care about your side effects. Because this is what happens in doctors' offices all over. When you have the low back pain patient, or if you have a chronic trigeminal neuralgia patient, so nerve pain, which opioids do work on nerve pain, like that. And you say, well, because you don't have cancer-related pain, I'm not going to treat you with opioids because they're really dangerous for you. You know, you get addicted, you'll have all these side effects. Where with a cancer patient, we say, you know, you don't get a gold star for going out with pain and suffering. Just take your opioids. The side effects are fine. That's just dishonest. So Pepin and Chapman really, this is a fairly new publication, challenged this whole categorization and classification that we should tailor how we prescribe things. Now, like I said, there's some evidence that in certain populations they don't work. Maybe we should do that. But the assumption that cancer is worthy of opioids with other pain isn't is probably a false assumption. So some modest step forwards, and then I'll quickly wrap up. So we desperately need. I mean, I'm not giving you for the practicing physicians. I'm not giving you many things you can grab onto for clinic next week. We need alternatives to opioids. Pfizer and Lilly have joined teams. I have no conflict of interest, but they have a non-opioid pain medicine that looks really intriguing, and that will hit the market soon. It's an infusion that lasts for about 8 weeks, and the initial data on it are really very, very impressive. Now, we'll see if it has other side effects, because it's a pretty complex drug, and I'm sure it's going to be very expensive. But we need better alternatives. Most of the alternatives that have been offered are not better. Methadone is still one of the best pain treatment we have, and it was developed by the Germans. And, we need attempts to minimize and wean opioids. We really need, if you have a clinic that prescribes opioids, you need to have attempts to get people off opioids. Some of the opioid epidemic is just taking the path of least resistance. So if it's easiest for the doc running the pain clinic to just refill. It's very lucrative. It's some people call them pill mills, but other people, if you review the charts, it looks like it's just a legit pain clinic, and they're just not trying to wean. They're saying, oh, you have worsening pain, your activity is poor, we're going to increase the opioid so you can increase activity and decrease pain. It's just not working. So I think we should really have specific protocols that the default is come off the opioid. In cancer pain, this may be if you've been cancer-free for a year, cancer-free for 2 years, it's time to really get you off. I have patients in my clinic that are 30 years cancer-free that I inherited. And I'm like, well, where's your pain? All over. Well, that's the opioid. Where was your cancer? Right here. Well, okay, let's get you off the opioid. Sometimes it works, sometimes it doesn't. Multimodality treatment, when it's shown effective. So these are things like acupuncture and cognitive behavioral therapy. I have to recommend multimodality therapy with a little, I'm a member of the our integrative medicine center, but I'm a critic of integrative medicine also, because a lot of integrative medicine is saying, oh, here's your prescription for mindfulness meditation and yoga, and I think both those are evil. That you're playing with Buddhist and Hindu practices that were formed in a religious context over hundreds of years, and you don't know what fire you're playing with, even if you look at it as calisthenics. That's not how any devout Hindu or Buddhist would view it. So I have a little hesitance, and I have a hesitance over some other types of alternative treatment that aren't shown to be effective. I think they should be shown to be effective before we prescribe them. And we need to go beyond the specific population, so specifically people like low back pain and fibromyalgia patients. There should be safeguards against diversion for all patients. So often we have the the high-risk patient group, and we have the chronic pain treatment group, and they get really specific safeguards against diversion and addiction. But then you have these the surgery patients and cancer patients that don't get the same safeguards. I think all patients should have safeguards. They should know that we're trying to do this for them. We're not trying to make their life harder. We're actually trying to protect them from dangerous medications. The use of drug monitoring programs has been great, especially as states. So now I can look up in Ohio as my patient comes in. I can see what my patient has gotten from a pharmacy from any adjacent state. I can see if they've gotten from any other prescriber. These are really effective programs. They should be used by everyone. They should be required if you're going to prescribe opioids. That includes dentists. This is a problem when you have people, non-physicians that have been granted prescriptive authority for pain medicine, and some dentists are saying, no, here's 20 pills, instead of maybe the 3 or 4 that may be needed for the next day. That's potentially problematic. I don't think that's the main culprit in the epidemic, but it is a problem. We should have risk assessments. If someone's is not predicted to be off the medication in a 1 or 2 or 3 week period, you should do a risk assessment for addiction before they're started. We do need dual diagnosis options. So when someone comes in, we do regular drug screens, even in our palliative clinic. So they can be sporadic. We can call someone and say, hey, come give us a urine sample or a blood sample, whatever we want to do, they have to come. Usually on our cancer patients, we try to make it where they can come in when they're getting treatment or something. But when they're cocaine positive or something, and our clinic policy is that we're not going to treat them with opioids anymore. Well, when they have bony nets and they're really sick and they're dying and you know how they have pain, it's really hard. It's just my clinic isn't set up to take care of patients with addiction. I don't have an addiction counselor. I don't have any of the other mechanisms to really help people with addiction. I ran a clinic like that in Birmingham at the county. I know that can be done. So the dual diagnosis clinic and options need to exist. We also do need to crack down on bad doctors and clinics. There are pill mills. They're very obvious. The cases that have been prosecuted are pretty obvious. Those should be cracked down on. I think that we can tighten up some more. The thing that you'll hear a lot about, especially physicians and nurse practitioners in the audience, education for clinicians and patients. So mainly will be for clinicians. They're going to start, DEA and state agencies are going to start requiring you take a webinar before you get your Schedule II renewal. I don't think that's going to do a lot, honestly. It's like Actique lozenges, the oral fentanyl. You have to do or RIMS, you have to do an online module. Well, most of the people that do the online module don't learn a thing in the online module because we already know it. But it's a step. It also really helps medical educators because it gives us money and it creates a bureaucracy that makes medicine and healthcare more expensive. And increases regulators. So more jobs in Washington and the State House. All positive. That was sarcasm, sorry. So I'm going to dive quickly into this one little bit that a lot of physicians don't know, and in my experience, no one practices. So this is from a CMS, an HHS brochure. This is the cover of it, and it defines drug diversion. Drug diversion is the illegal distribution or abuse of prescription drugs or their use for unintended purposes. That's a pretty broad definition of drug diversion. Okay, and it's that this publication is the prescriber's role in preventing diversion. Okay, what's the provider's role? I mean, most clinics, if they catch someone in diversion, may say, I'm not prescribing for you anymore, right? And may put a flag in the chart. Some clinics say, stop doing that, and keep prescribing. What does CMS say we should do? Physicians and other prescribers often have the first opportunity to identify, control, and report diversion. If a prescriber suspects the drug diversion has occurred, the activity should be documented and a report should be made. This is the federal government. This is CMS. This is Medicare, Medicaid. Notify the U.S. Department of Health and Human Services, Office of Inspector General, local law enforcement, or, thankfully I didn't say and, local fraud alert networks of suspected drug diversion to report theft or loss of controlled substance, notify the DEA. How many people do that? How many clinicians in the audience? Clinician of any type. Okay. How many people of you know that that exists? I mean, have heard of that happening? You've heard of it? Yeah, I mean, I know that if someone calls and says, hey, Johnny's selling his oxycodones outside of Walgreens right now, it may be reported. But I can tell you that all the health systems I've worked for, I've brought this up, and legal has said, no, this is really opens you up for risk. Really opens you up for risk because it's confidentiality. You don't have a duty to report. There's not a duty. This is not a law. There's no regulation saying you do it. It's just a publication. And their concern is yeah, CMS can say this all they want, but until they give me immunity, if they give me immunity, then I'll do it. That's what my lawyers want. They want to have a regulation, a federal regulation, a state regulation saying if you violate confidentiality in these circumstances, you're immune from all those regulations and laws that are passed that say we can't violate confidentiality. Now, I think it's there. So in Ohio, I'll be Ohio-centric. So this is an Ohio statute. Failure to report a crime or knowledge of a death or a burn injury. No person knowing that a felony, and drug diversion is a felony, has been or is being committed shall knowingly fail to report such information to law enforcement authorities. No person shall do this. I think that says that we have a duty to inform if we know a felony is being taking place. I think at least Ohio statute protects me. My lawyers aren't completely convinced yet. So I do think we need greater clarity in all these drug task force that are being formed across the country in every state, and DEA has them, Institute of Medicine has them. I've talked to some of these folks. They're trying to do a good job, but we need clear immunity, clear protection. I think on this aspect of trying to if you start with trying to stop bad docs, bad clinics, and people that are obviously doing something wrong, I think that's at least an easy place to start. Now, there are problems. If we start reporting our patients, it violates this trust, that patients, can a drug abusing patient come to us and be honest? That's a real challenge. I don't know. I do know that if someone's taking my prescription and selling it to people and it could harm them, I want that to stop. And I may be willing to put trust a bit at risk, to do that. But to do it right, we need a good relationship with law enforcement. We have a little law enforcement crisis in the country too right now. A lot of scrutiny, some of it warranted, much of it not. John Pepin, who I mentioned earlier, he has a great relationship with his narcotics officers, and he reports, and so do others. So it can happen. But the answer is not send these people to jail or prison, but having addiction programs and drug rehabilitation. So I'm hoping there are a lot of states are starting these rehabilitation and addiction alternatives to jail and prison. Hopefully, if we combine efforts, we can try to really address addiction more than just criminal activity. And the challenges that we have is we just have a really messed up, confused society. So, this is the Nancy Reagan just say no, which is hyper scrutinized, that doesn't work. This is not deer droppings. These are buckeyes. I think they look like deer droppings, but they're buckeyes. And Ohio State is now tobacco-free, but this is Ohio is just about to pass medical marijuana, and this was one of the campaign marijuana buds that was going around. It's the same people that are saying tobacco is the new unforgivable sin. I mean, it's so popular to say that tobacco is the unforgivable sin, are saying, oh, but we need to smoke pot in order to be healthy. This is confusing. So what to do on addiction and opioid use, I think we're really confused. We don't know what to think about opioids. We don't know what to think about mind-altering medications. And tobacco is not mind-altering. It just mainly affects heart and lung disease. And vaping has changed this as well. Anyway, I could say more, but I'll take a couple of questions when I have time. Thank you for listening.